Welcome to this educational presentation from Professor Mohammadi's Teaching Archives. Today, we will discuss a practical and clinically oriented approach to EEG interpretation in children, focusing on common pitfalls and how to avoid them. Accurate EEG interpretation is not simply the recognition of waveforms. It requires understanding the child's age, clinical history, medications, reason for referral, and the specific clinical question being asked. The core message is that a well-interpreted EEG is more than identifying abnormalities. It is the integration of EEG findings with the clinical picture to improve diagnostic accuracy and patient care. Next slide, please. This slide presents a structured framework for EEG interpretation. The process begins with the clinical question. We must ask, why was the EEG requested and what decision will it support? Next, we review the patient context, including age, history, examination findings, medications, and the child's state during the recording. Then we perform a systematic review of the EEG, including all channels, epochs, sleep and wake states, activation procedures, and video when available. After that, we classify pattern. Is it a normal variant, an artifact, a focal abnormality, or an epileptiform discharge? Finally, the report should be actionable. It should answer the clinical question clearly, state limitations when needed, and support appropriate clinical decision-making. Next slide, please. The first major pitfall is ignoring the clinical context. When the EEG is interpreted without knowing the child's history, medications, age, or clinical question, normal variants may be overcalled as abnormalities, and important findings may be missed. To avoid this, always review the referral question, clinical history, medications, and relevant examination findings before interpreting the tracing. If the request is unclear, ask for more information. The second pitfall is misinterpreting normal variants. Children have age-dependent EEG patterns. Some normal patterns may look sharp or unusual, but they are not necessarily epileptiform. To avoid this error, use age-specific EEG standards, assess symmetry and morphology, and compare suspicious patterns with contralateral regions. Before labeling a waveform abnormal, ask, is this expected for the child's age, state, montage, and clinical context? Next slide, please. This slide highlights the importance of balance in EEG interpretation. The third pitfall is overcalling epileptiform discharges. Artifacts, benign variants, muscle activity, eye movements, ECG contamination, or electrode artifacts may be mistaken for epileptiform activity. This can lead to incorrect diagnosis, unnecessary treatment, and parental anxiety. To avoid this, use proper artifact recognition techniques. Check the video, change montages and filters, assess the electrical field, morphology, and reactivity. The fourth pitfall is missing subtle or focal abnormalities. If the interpreter stops after seeing the first abnormality, or reviews only selected parts of the tracing, focal discharges, subtle slowing, or interictal abnormalities may be missed. The solution is a systematic review of the entire EEG, including all channels, all epochs, sleep and wake states, and activation procedures. The key principle is balance. Avoid both overcalling and undercalling. Next slide, please. The fifth pitfall is overlooking clinical events. In pediatric EEG, event correlation is essential. If push-button events or caregiver-marked episodes are not reviewed carefully, electroclinical seizures may be missed, or non-epileptic events may be misclassified. Always review the video during events and correlate EEG changes with the clinical semiology. The sixth pitfall is ignoring medication effects. Anti-seizure medications, sedatives, and other drugs may alter background activity, produce generalized slowing, or suppress EEG rhythms. Without medication context, these changes may be misinterpreted as pathological. To avoid this, review the medication list, dose, timing of the last dose, and possible sedative effects. In practice, strong EEG interpretation depends on combining semiology, video, EEG findings, and medication context. Next slide, please. The seventh pitfall is inadequate reporting. An EEG report is not simply a waveform inventory. It is a clinical communication tool. An unclear, incomplete, or non-structured report may cause misunderstanding and inappropriate clinical decisions. A good pediatric EEG report should include the background, abnormalities, clinical events, activation procedures, impression, and recommendations when appropriate. The impression should be concise, specific, and clinically linked. It should answer the referral question directly. When uncertainty exists, the report should state the level of certainty and limitations clearly. Clinicians need to know not only what was seen, but also what it means for the child's care. Next slide, please. This slide translates the previous pitfalls into practical diagnostic safety checks. The first trap is premature closure. This occurs when the interpreter stops after identifying the first abnormality. The safety check is to continue reviewing all channels and epochs systematically. The second trap is pattern-only reading. This means interpreting waveforms without considering the history, age, state, and medications. The safety check is to interpret morphology within the clinical context. The third trap is artifact blindness. Movement, ECG, muscle activity, and electrode artifacts can mimic epileptiform patterns. The safety check is to use video, montage changes, field analysis, and reactivity. The fourth trap is non-actionable reporting. Describing EEG findings without explaining their clinical meaning reduces the usefulness of the report. The safety check is to write a concise impression that supports clinical decisions. Next slide, please. This slide can be used as a practical checklist before finalizing an EEG report. Before reading the EEG, review the request, clinical notes, patient age, and indication. Ask for missing information when necessary. During the review, examine all states, including wakefulness, drowsiness, and sleep. Check the video and marked events, and use montage and filter adjustments when needed. When deciding whether a pattern is abnormal, assess the electrical field, morphology, symmetry, reactivity, and relationship to age-specific norms. Before signing the report, make sure the language is clear, concise, and specific. Most importantly, ensure that the report answers the clinical question and provides useful guidance when appropriate. Next slide, please. This slide summarizes the golden principles of accurate pediatric EEG interpretation. First, know the patient. The EEG must be interpreted in relation to the child, the referral question, and the clinical setting. Second, know normal development. Pediatric EEG changes with age, and normal developmental patterns must not be mistaken for pathology. Third, watch and correlate. Video and clinical events are essential for understanding electroclinical meaning. Fourth, seek balance. Avoid both overcalling and undercalling. When uncertainty remains, state it clearly. Fifth, discuss when in doubt. Peer review and second opinions are valuable, especially for ambiguous patterns. Finally, always remember the goal: accurate interpretation that improves patient care. Next slide, please. The take-home message is straightforward. Start with the clinical question, not the waveform. Separate normal developmental variants and artifacts from true epileptiform abnormalities. Review the entire recording systematically, including all states, all channels, clinical events, video, and activation procedures. Report clearly and clinically. Include the background, abnormalities, events, activation procedures, impression, and recommendations. Better EEG interpretation leads to better diagnostic accuracy and better patient care. Next slide, please. Thank you for your attention.